Get started. Thank you everybody for joining us today. This is our HIE office hours. We've been doing this series, and today we're going to be discussing promoting interoperability programs and how My Health kind of intertwines with those and can help you satisfy some of the objectives outlined within those programs. So today, I'll give a quick just introduction and overview of the Promoting Interoperability programs. We'll talk both hospitals and clinics and what they have to do. I'll give you a few more details on measures that are focused specifically on interoperability and that exchange of health information. And then we'll kind of talk after that about what you can do if you're not connected to My Health, what the next steps are, and then give you some kind of resources and other regulatory updates that are going on right now. So just getting started with promoting interoperability on clinicians first. So for clinicians participating, there's 3 different options within the quality payment program. The first is traditional merit-based incentive payment system, or MIPS. Then we have alternative payment models that includes things like ACOs, or accountable care organizations, and some other innovative models that CMS has put out there. And then also this past year, they introduced the new MIPS value pathways. So no matter which of those options you're participating under, you will have to report promoting interoperability objectives and measures. So the same promoting interoperability measure set is reported for all of the options that you participate in. The quality reporting requirements are going to differ whether you're doing the traditional MIPS or maybe in an ACO, but the promoting interoperability part's the same. The reason they do the promoting interoperability is because that's how CMS is assessing your use of health information technology. So they're making sure you've got an EHR in place and making sure that you're taking steps towards patient safety, safety of health information, and then things like health information exchange and e-prescribing that tie in with all the health IT technology. So hospitals, promoting interoperability is a single program. So for clinicians, you have the promoting interoperability category. That's one piece of the pie. You're also going to have quality reporting, improvement activities, and cost category. So for clinicians, promoting interoperability is one of 4 performance categories. For hospitals, promoting interoperability is its own separate program. So for hospitals, instead of basically trying to get a score across multiple performance categories to increase or decrease your reimbursement, hospitals are reporting to these objectives to show that they're using health information technology and to avoid downward penalties. So if hospitals don't participate in the Promoting Interoperability program, they can get a reduction to the increase in the IPPS rate for the year if you're a subsection D hospital. And then critical access hospitals, if they don't participate in the program, can get their reduction of reasonable costs drop down to 100% flat rate instead of that increased rate that they currently get. So promoting interoperability, this is the new swing of meaningful use. There's some changes that are going to be coming over the next years, but still the foundation that all of it is that health information exchange and utilizing health information technology. So for both hospitals and clinicians, they're going to have the same set of objectives and measures that they attest to. There's a few slight differences. Hospitals have to report a few more public health measures, but for the most part, they're really the same across all of the settings of care. So the 4 performance categories you have within promoting interoperability include e-prescribing, health information exchange, provider to patient exchange, and public health and clinical data exchange. So as you see, a lot of exchange. That's really the focus, is that health information exchange. Today, we'll just talk about the HIE and the public health data. For e-prescribing, that all has to go through the SureScripts network for that to count. So if you're sending prescriptions differently, not through that electronic means, then you're not going to meet that objective. There also is an objective tied in there to be participating in the prescription drug monitoring program. So just making sure you're doing those e-prescriptions and connected to the PDMP in the state. The provider to patient exchange is really what most of us look at as the patient portal objective. So how are you making that health information accessible to patients? So the ones that we'll focus on today, HIE and the public health, are things that My Health's HIE can help you to accomplish and increase your scores for this promoting interoperability program. So health information exchange, this objective, within the past couple of years, they've changed it. In the past, you only had one option, and that was this one that we'll discuss first. So you had two different measures that you'll report to. One is the sending of health information exchange, and the other is receiving and reconciling health information. There are two other options for reporting this. This option one is the only one where you have to submit numerator and denominator data. So if you choose option one, you will pull these reports out of your EHR. You'll send a separate numerator and denominator for each objective. And each of those individual measures is worth 15 points for a total of 30 points across the objective. There's no exclusions for hospitals on this, so you have to report this measure. Clinicians, if you have fewer than 100 referrals or transitions of care during the reporting period, then you don't have to report this measure. I will emphasize that this year, the reporting period jumped up to 180 days. So for promoting interoperability programs, you're going to have to report 180 consecutive days worth of data. In past years, up until now, it's only been 90 days. So if there's anyone who has claimed this exclusion on this measure in the past for those referrals or transitions of care, that may not be an option since the reporting period is quite a bit longer. Within the EHRs, this is still typically done through direct messaging. So in most EHRs, the way that it's built to count for your report, you're going to have your own direct message that's tied directly to that provider. And then anytime you're sending those referrals, you'll generate a summary of care electronically within your EHR, and then you'll need that receiving party's direct address to be able to send it to. I know in the past that has caused some issues in some bigger systems or maybe in small practices that are trying to refer patients to a larger system in the metro areas. It's hard finding those direct addresses and keeping up to date with all of those. So as of right now, this is still an option. You can report these two separate measures for 15 points each and a total of 30. Now, the other options that you have this year, option 2 is health information exchange, bidirectional exchange, and then option 3 is enabling exchange under TEFCA. So both of these are just a yes/no attestation. You don't have to report any numerator denominator data. You're just saying, yes, we're connected to an entity that can do these things and moving forward with the objective. So health information exchange, bidirectional exchange, the things that are important to know about this is you have to be connected to a HIE or health information network that exchanges data for all of your unique patients. So you can't just be exchanging data with this HIE on just a subset of patients. All of your transitions of care need to go through this. I will give the one disclaimer that the mental and behavioral health data is excluded in a lot of these. So I'm not talking about specifically those cases, but you can't really pick and choose that, hey, I want to send this referral through an HIE. I don't want to do this. They want you to be consistent across the board on how you send those referrals. The other thing to note here is that to meet this objective, you have to exchange across a broad network of unaffiliated partners. So if you're within a big health system and it's just your system that's connected, that doesn't meet the spirit of this objective. You would need to be able to connect to outside entities and make sure that they're not all affiliated within a management group or within a single EHR. It's got to be different entities, different EHRs that are exchanging data there. The TEFCA, that is really what that stands for, is Trusted Exchange Framework. So that is really just more of a nationwide interoperability framework. So if you're participating as a signatory to that framework agreement, or participating with an entity that's doing that, just like with the bidirectional HIE, if you're connected to them, you're just going to test yes, and you will get the points for that objective. The one thing that I will mention is really important. Anytime in these programs where you are just saying yes or no to something and not reporting actual numbers, make sure that you have that supporting documentation to help you withstand an audit. So if you get audited within this program, and Medicare has, I think it's 6 or 7 years that they can go back and audit data for promoting interoperability or meaningful use programs. If they audit you for this, they're going to want to see that you have an agreement in place with that HIE, see some type of screenshots showing that you actually are exchanging data or how that process works within your EHR and HIE system that you're connected to. So just make sure that you have all that information on file if you're using one of these yes/no objectives. So just to kind of pause as we're going through these and talk about how MyHealth can help. So MyHealth has a provider portal. This can help providers better to monitor and improve their care. It does this through reducing healthcare costs, really helps with that redundant testing, hospital admissions, emergency department visits, helps improves care coordination, patient experience, and the quality of care. Also, there is already tons of patient data across a broad network of affiliated partners, which we just talked about is important with that HIE bidirectional objective. So by connecting to MyHealth, you'll get access to the provider portal, and that meets the spirit of the HIE bidirectional exchange. So once you connect, MyHealth will also provide an engagement letter, things like that you can keep on hand, as well as screenshots just to help you withstand an audit if that is your option for those measures moving forward. MyHealth also has a couple of other reports that tack on to this provider portal. They have single sign-on, clinical data integration, care gaps alerting. So a lot of different functions on the back end and reports that are available to you to help you, one, improve patient care and care coordination, but also two, to help you meet these objectives within these quality programs that you're required to participate in. So the next objective that we'll talk about is the public health and clinical exchange objective. So for this, you have to report to a couple of different registries. Immunization registry reporting is required for both hospitals and clinicians. Clinicians will also need to pick up a second one of these 5 options. So the electronic case reporting, public health registry, clinical data registry, syndromic surveillance. So clinicians just have to do 2. Hospitals will have to do all 5 of the objectives. If one of these is not available within your service area, so for instance, here in Oklahoma, we don't have syndromic surveillance reporting available through the state. So you are able to exclude that, but still get credit for meeting the measure. So to go along with this, there's a couple of different ways that you can be engaged in reporting this data. So they say that you need to be actively engaged with a registry to get credit. There's 2 different options of that engagement. So option 1 is that pre-production and validation. This means basically that I've signed up with this registry to participate, and we're going through the processes to be able to exchange data electronically and submit what we need to. Option 2 is the validated data production. So option 2 means we've signed up to participate, we've gone through all the hoops to get the data going across seamlessly, and you have that live feed in place. So if you are in either one of those buckets, that counts for active engagement, and you get to say, yes, we're doing this for the public health reporting. So you have to meet all of those required measures within this objective to get the full points. So for clinicians, you'd need to do the 2 required measures and you would get 25 points for this objective. For hospitals, you report a yes or no on all 5. If you are a yes or excluding those, then you get the full 25 points on this objective. There are 5 bonus points that are available for reporting to an additional registry. So if you have any kind of national level registries you're reporting to, there's a couple of clinical data surveys that you can do through the National Healthcare Surveys through CDC that will count for those. And then MyHealth also has a COVID registry that's active. It got stood up during the pandemic when all of the COVID stuff was really going strong, and that registry is still active. So MyHealth has another option there to where you can pick up those 5 bonus points and kind of bump your score up a little bit if you're on the edge or verge of maybe running close to a penalty, or if you just need a few extra points to give you that cushion and make you feel a little better. This is something too I will mention. So I talked about the 180-day reporting period for this year. Whenever you plan on starting that reporting period, you have to be in active engagement with these registries within 60 days of the start of it. So if you haven't already been in active engagement with the state health department or with MyHealth for registry reporting, that's something that I would put on your radar to get done pretty quickly, just because we're getting close to where we're getting towards the last 180 days of the year, and you'd need to make sure you have all those technical capabilities and everything in place to get credit for this measure. Sorry, so I talked about this already, but the hospitals, so they do, it's 4, not 5 measures that they'll have to report on. So clinicians have the immunization registry and then case reporting, and other registries are optional. Hospitals, you have immunization, syndromic surveillance, electronic case reporting, and then electronic reportable laboratory results. So same thing here for the hospitals. Syndromic surveillance reporting is not available. The immunization registry and electronic lab reportable data is available through the state. So check with the state health department on that. And then also just to inform you, MyHealth is working with the state on the back end. So there may be options in the future to where they can help facilitate that data transfer for you if you're connected to the HIE. So it's just some other options down the line to just make that reporting burden easier on facilities. So same with hospitals, total of 25 points, and then 5 bonus points available if you submit to any additional registries outside of those required ones. So here, this is just an overview of the scoring. So as we talked about, there's 4 objectives within the program for both hospitals and clinicians. And then these are the measures that are associated with each. So in e-prescribing, you've got 10 total points, 10 for the e-prescribing and 10 for the prescription drug monitoring program. Health information exchange is a total of 30 points. So again, just by connecting with MyHealth and getting that process going to where you're submitting data on your transitions of care, that will meet option 2. So connecting to MyHealth would get you that full 30 points for that health information exchange objective. Provided a patient exchange, so again, that's your patient portal, is worth up to 25 points. And then the public health and clinical data exchange, 25 points for those required measures, and then additional 5 bonus points for measures outside of that required set. So this, again, is just something that MyHealth is a great tool. Not only is there funding available to help you get connected, but they can help you check some of the boxes and get up to at least a minimum of 35 points if you connect to them for the transitions of care and for that COVID registry, and then possibly more in the future with helping submit some of that other public health data. So scoring for these programs, For clinicians, and I'll just use traditional MIPS because with ACO scoring and some other alternative models, it can get a little bit more complicated. But for that promoting interoperability program, it's 25% of your overall score. So how you did across these measures, the total points that you get, you would multiply by 0.25, and then that's going to give you your performance category score. So again, this is one piece of the pie. For clinicians, your additional points will come from your quality categories, cost, and improvement activities. For hospitals, you have to have at least 60 points across all measures to avoid penalty. So as I mentioned, My Health could, by connecting to them, you could get a minimum of 35 points. So you're already halfway to that total with the capabilities that My Health could provide you with there. I have these out of order. Let me touch on this one real quick. So this isn't within the promoting interoperability program, but since it's kind of tied in, I did want to mention it. So hospitals through the IQR, OQR program, they have two different social or drivers of health measures that they will have to submit. One is the screening for patients for health related needs. The second one is that screen positive for those health related needs. So you would need to screen individuals for food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. So this is a new measure for hospitals. Through that IQR program, they will need to report those two separate measures. Clinicians do have an option to report the one measure where you're screening individuals for these 5 health-related social needs, and that can count to your quality reporting score. So clinicians have to report 6 quality measures, and this screening for social drivers could be one of those measures. The reason I wanted to mention this is because, again, it's kind of tied in with the promoting interoperability reporting and other quality reporting. And My Health also has a module here that they have built in through an app, the ability to be able to screen patients for these social needs. And not only just screen them, but connect them to services within their region. So this is just another great tool and service that My Health provides that can, again, on the back end, tie in and help you satisfy some of those quality reporting requirements. So your next steps, if you haven't already connected to My Health, I just want to mention that there is funding available through the state to connect to My Health. Through the Connection Fee Assistance Program, which was passed through our legislature. They've enabled one-time funding for connection to the state designated entity for health information exchange, which is currently My Health. So step 1 is to complete an application to join My Health. So just a quick form that you'll fill out, and then somebody from the My Health team will reach out to get you going through that process. Step 2, after filling out the application to connect to My Health, is to complete that Connection Fee Assistance Program application. So this is what would allocate money from the state for you to be able to connect to My Health. If you try to fill out the CFA application and haven't filled out a My Health application, that link there will take you to the My Health page. So just making sure you get those in order first, but just kind of a little helpful thing to keep you on track there. So once you receive approval from the Office of the State Coordinator that you've been accepted for that CFA program, then the My Health team will reach back out, begin that process of onboarding and getting you connected to start submitting data. We do have a couple of individuals on the OFMQ team that are working with My Health and with the state to expedite this onboarding process and get as many people signed up for the program and connected as we can. There are some kind of timing limitations on that funding. So this is one of those things that if you think you're going to connect to the HIE within the next month or year or next 5 years, this is your opportunity to get some funding help and kickstart that venture for your organization. So if you have any questions specifically about the Connection Fee Assistance Program, I've included Mike and Michael's information down there, or you can reach out to anybody on the My Health team. These are a few resources that I just wanted to share. The QPP resource library, that's going to be for clinicians. So anything having to do with the promoting interoperability objectives and measures that we talked about today are going to be on there. They'll also have lots of information about quality, improvement activities, costs, other things tied into that program. The PI programs resource library, that's going to be specifically for hospitals. So hospitals, again, that's a separate reporting program outside of your IQR, OQR reporting. So those are all your hospital specific resources. And then I've also included the links here for the OK Shine, the Oklahoma HIE application, the My Health application, and the Connection Fee Assistance application. Oh, and then I see we've also got, yeah, same thing in the chat. So there's a link there in the chat. We'll send these slides out after the presentation, but there's a link there that will take you to that CFA application as well. One other thing I wanted to mention, the Office of the National Coordinator recently released a proposed rule. So this is called the HTI-2 rule. It's focused on improving patient engagement, information sharing, and public health interoperability. This is not necessarily as geared for providers, but looking at a lot of the kind of technical specifications on the back end, some things that are going to be required of EHR and health IT vendors moving forward so that we can continue to improve interoperability between healthcare providers and with the public health setting. So just wanted to share this information with you if that is of interest to anybody, or so you can just kind of stay up to date with the latest regulatory stuff going on so you're not caught off guard by anything. And with that, we will open it up for questions. I think I see one in the chat, but if you have any, you can share in the chat, or if you want to raise your hand, we can take you off mute.
Yes, there is a question in chat. You mentioned that clinicians need to pick 6 quality improvement measures to qualify. Where are the quality improvement measures listed?
Okay, yeah, so I have, let me go back. This QPP resource library, that will have, you can click on promoting interoperability, quality improvement activities, and it will give you detailed measure lists for all of those measures. I will warn you, there's a couple of hundred in both the quality and the improvement activities, so it can be a little overwhelming. The good thing is they have some tools built in to where you can filter that by provider type. So by family medicine or cardiology or orthopedics, so whatever your specialty may be, and it will kind of help narrow that down some for you. I'll drop my email in the chat as well. So if you have just any general questions about regulatory requirements or quality reporting, kind of separate from HIE, feel free to reach out to any to me, and I'll get you connected to one of us on the OFMQ team. Since we are talking about promoting interoperability, I did want to mention that there are some deadlines coming up for hardships. So if you are a hospital that did not attest to this program last year, you would need to file a hardship this year. So critical access hospitals have until November to submit that hardship. But subsection D hospitals, other PPS hospitals just have until the end of August. So make sure that if you didn't report in this program last year, that you fill out that hardship application to cover yourself this year. Okay, I don't think I'm seeing any other questions. Just again, want to thank everybody for joining us this afternoon. Hopefully this was informative just about promoting interoperability and quality reporting in general, and then also letting you know how My Health can really help facilitate and improve your scores through these programs as well. Again, I encourage everybody, if you haven't already, go fill out that connection fee assistance application and get those funds allocated to you. We've got people signing up every day, and we've got a team of people that are getting them onboarded. So make sure that you have taken advantage of that opportunity, because I can promise you health information exchange is not going anywhere. As I mentioned, with all of the O&C rules and kind of the regulatory stuff that's happening on the back end, that's usually laying the groundwork for future things that clinicians and hospitals will have to report. So again, just take advantage of this opportunity that the state has provided to help you connect and get a jump start on that. Again, thank you for joining us. If you have any questions, again, reach out to anyone from the OFMQ or My Health team, and we will be sure and get these slides and other resources sent out to you after the program.